Okay, good morning. Thank you, Dr. Prasad and Dr. Ng. Okay, our next speaker, it gives me great pleasure to introduce our honorary professor, Prof. YK Chan, Professor Chan Yu Kuen from our Department of Anesthesiology. She has trained generations of care providers in ensuring patients are safe. So it makes her the right person because she will be sharing her vast knowledge and experience so that we will do the right thing, the right way, so that we're on the right side of justice. So without further ado, Prof. YK, please share your insights with us.
Thank you, Prof. Jahan, for the very kind introduction. And also thank you for allowing me this platform to share something that I passionately believe in. I'm going to try to share my screen and we will see whether I can do it without too much of a hassle. Jahan?
Yes,
Jahan?
Prof. I can see your slide.
All right. Okay. So I have got no conflict of interest to declare. And to start the discussion and presentation going, I would like to share with you how judges come to decide on a case. And most of us have the impression that judges are wise and unbiased and all-knowing. Most of them, however, are actually very old. They originally were lawyers to begin with, but due to the collection of a lot of experience, they are then anointed to be judge. All right. And as I said, wisdom comes through the age that they actually have. And you can see a very old judge here. What they actually do is they sift through all the evidences on both sides, the plaintiff as well as the defense itself. And when you talk about medical defense and medical cases, the plaintiff is usually the patient who has sustained some damage and brings the case to the court. And the defense is usually the doctors who have actually taken care of the patient and would try their very best in a court hearing to tell the judge that the damage has not been caused by him as part of his care provision. So the judge then has to look at all the evidences from both sides, weigh them accordingly, and then decide who actually is not in the right. And these evidences that I talk about in the medical defense itself actually come from the clinical notes that all of us write as part of the medical team, whether we are nurses, whether we are doctors, or anybody else who help with the care provision of the patient. I'm sure a lot of us who have been following the 1MDB court hearing in the federal court discussion are very aware of this particular picture where boxes of evidence were hauled into the federal court. Now, in the medical defense, as an expert that I am, I usually have to look for evidences that comes in one box or sometimes two, all the clinical notes of the patient. So actually the medical record itself is the most credible evidence that all of us can get into when a legal proceeding is actually on the way. So when I actually, who don't take care of the particular patient, has been asked or invited by the court to look at the situation or to look at the case, my role is to plow through the boxes of evidence and see what has actually transpired during the care itself. Now, most of us feel that, oh, we shouldn't write too much. After all, we can remember. It is not quite so, because if you consider the number of patients you're going to see during your lifetime career, this has been estimated by somebody that I managed to get data on, and it says in a 40-year career, you are likely to see 40,000 individuals. So if you actually put them all together in a mathematical form, on the average, for every year of your service, you are probably going to be seeing 1,000 individuals. So you are unlikely to remember the details of all the care that you have actually put into this 1,000 individuals itself. For me, at my stage of life, I can't even recall some of the names. If somebody says, okay, you know, you've taken care of Miss X and Miss X is now kind of going to sue you, I won't remember who Miss X is. So it is therefore important that you write details of your care so that if a case is brought against you, you can actually go back to the medical records in the medical record office, who is supposed to keep all the notes, clinical notes of the patient somewhere, so that we can all have access to it when a case is brought against you. So how long should the medical record keep this data? Actually also relates to how long can a case actually be brought against you in court. In the Malaysian context, if you look at what I've pointed out to you at the arrow here, it says 36 months. This is in relation to a death that you may have brought about. But if it is some damage other than death, it may be up to about 7 years. However, if you're taking care of a minor, like some of us do, if we are involved in pediatric care or in obstetric care or in obstetric anesthesia care, the statute of limitation, which is how long the case can be brought to court, it can be up to about 18 to 21 years, depending on the definition of what an adult is. I think for us now, we have brought 21 years back to 18. You know, that's when we become adult and are able to vote. And on top of that, once the person becomes an adult and he's damaged because of a problem in delivery, then it is 18 plus another 7 years. So you can see the amount of time that will lapse before the case is actually brought against you, and you have absolutely no memory of what has transpired in care. So it is very important, therefore, to be meticulous in sorting out your documentation. And most of us as care providers can be called as witness of fact. Now, what's the difference between witness of fact and an expert witness, which I call myself as? Now, a witness of fact is actually the provider involved itself. So they, when the case is actually brought against them, most times they will be asked to clarify what they have actually done in terms of care. And again, as I said, they have to actually give written and oral evidence, which is clear and concise. And it comes from the clinical records and notes that you have made at the relevant period of time, at the time involved in the damage or the injury itself. So the difference between the witness of fact and an expert witness like me is, as an expert witness, I have absolutely no involvement prior to being called into assisting the court. So what exactly am I? I'm actually a specialist in the field. In this case, I'm an expert in anesthesia and probably acute care provision, where my expertise is called upon to look at the evidences in the case. That means look through all the notes where the evidences are of how that care has been provided, and then translate it into a form that the public as well, especially as the judge, is able to understand. So when I appear in court, after writing the expert witness report, when I appear in court, they can actually ask me anything with regards to the care and how it should be practiced, what has been done rightly and what has not been done so well. So because it is all done under oath, I have to tell the truth. And I am also supposed to be impartial with regards to what I know of that particular care. So because the clinical notes contain all the evidences, we are actually asking you to pay a lot more attention to that, because what it says here, medical documentation is an essential aspect of the patient care processes. Now, you would recognize that in your undergraduate as well as your postgraduate training, we teach you so much about care, but we fail you in this particular respect. We never teach you how to document properly. And it says here, it is an essential aspect of patient care process. So how can you be giving good care if you are not mindful of this particular aspect of care? And this recording of your care is actually information that is useful not only for diagnosis and treatment, but a way of communication so that all the providers can follow what the care should be and align their care accordingly to meet the patient's needs. And it can take many forms. Most of us are probably just able to recognize things like medical history record, the medical test in whatever form, even the operative report, discharge summary, and even mental status examination. I've left out quite a lot because I think there's no space, but I'm sure anything that pertains to the care of the patient is fodder for scrutiny when a case is brought to court. While a fair amount of our documentation may be structured, things like medication, the lab tests and all the other tests that we have, a lot of our clinical notes documentation are unstructured. And a lot of us are at various stages of competency with regards to this documentation. As I said, first, we're not taught in medical school. Secondly, our consultants never insist on a certain standard of documentation. So what should the document then contain? I'm going to walk you through in quite great details what you should be doing so that this may become your first step in the learning process. Please record your most current information. That means, as soon as you've seen the patient or during the care, now that the computer is right in front as you see the patient. In fact, we've been accused sometimes to be just looking at the computer to record our care instead of looking at the patient. But whatever the way you do it, make sure you write down whatever has occurred and the evidence has to be appropriate and timely as well. I mean, timely done. So you have to have pertinent information. Now, what exactly is pertinent information? Well, it says that if you are going to be taking over the care of this particular patient, you would like certain information, and that would be a good guide as to what you should put in. So if you're going to ask your friend, hey, when was this patient admitted? Why are you, worried about this patient? All this needs to go right into the information or documentation of the patient. And then you will be making decisions. Please write down the rationale for those decisions as well. In fact, these decisions, as well as how you make it, need not be lengthy. In fact, simplicity is the new complexity. You will also find that as you move further and further up the scale of the hierarchy of care, you as a consultant will also find that you make things very simple, and it becomes very succinct for you as well as for everybody who needs to get at what the care has been like. And if you have got an informed consent, make sure you write about the discussions, the risks involved, the benefits that you have discussed, as well as the alternative that you have shared with the patient. And when the patient is for discharge, it is important to include the time of discharge and any action-specific directions. It is important that you give very clear instructions, like if your temperature doesn't return to normal, say by Tuesday, call me. So this is a very specific instruction to make sure that the patient knows as well as you have done it. Similarly, with follow-up plans, include them if you are not ruling out a more serious or life-threatening diagnosis. This is to cover you just in case the patient takes a turn for the worse. And all patients' complaints and response should be included into the notes as well. And, although we don't use a lot of phone conversations, maybe we do now post-COVID and intra-COVID pandemic, all this needs to be recorded into the notes. I think some countries have more telephone calls recording than others. We haven't come to that stage, but be mindful that all this needs to go into the notes so that we do not have gaps in documentation, so that a person like me trying to read the notes will try to figure out, you know, the sequence of events and why care has changed in a different direction. And if you decide to terminate your patient-clinician relationship, please document it down so that you know that, you know, any other damage incurred after that particular date does not come from you. Missed opportunities and attempted follow-up needs to also be recorded so that, you know, if this patient is a constant person, is a person who constantly misses his or her appointment, you know that the patient has been responsible through a non-compliance, and the damage has potentially or partially come from that failure to follow instructions. All medications included should be recorded, including the allergies and prior adverse reactions. And if you're dealing with the obstetric patient, or if a patient is pregnant but not dealing directly with the obstetric part, please also record that, because it's very important, especially if damages occur to the fetus. And if there's conflicting data from two providers, please make sure you record that as well, and then document your differential diagnosis if your diagnosis is different from prior diagnosis, and put down what you think in terms of your opinion and your rationale. What should not be documented? It is important not to put derogatory or discriminatory remarks. Do not say if a patient is obese, she's a fat soul or whatever. This is very unbecoming of our profession. We don't describe it in the notes. Even if we remark it elsewhere, we don't put it into the notes, because it will actually detract from your credibility, and it can be considered very disrespectful and prejudicial as well. Now, I have also seen arguments or conflicts between physicians, nursing staff, and administration, all recorded into the notes. This also is not something that we encourage. Again, it will detract from our credibility. And if there is any statements made, especially by the patient or the family, with regard to treatment, especially when there are poor outcomes, this should not be presented as facts. So you should put quotation marks to show that, you know, these are what you were told by the patient. And if there has been an adverse event, please do not put finger pointing or self-serving statement. So do not gloat and say, oh, you know, this Dr. X was, you know, totally wrong in doing what he did. Please do not do that. And if there's any non-patient care information, like, you know, ultimately, we are going to file an incident report on that particular care, or you're going to refer to our legal person, please do not write it into the notes as well, because a person like me reading through will say, yeah, at that stage, they were already realizing that their care had gone wrong, and they were doing a lot to, you know, to have some closure for themselves as well as for the patient. So it will give the court ammunition to explore what exactly has gone wrong, even if the care had been excellent. So what are the pitfalls to avoid? I've mentioned the incident reports. Now, it is very important to put the time and date of all entries into the medical record. You know, if you are looking at electronic record, yes, most of the time and date will already be there. Now, if you actually want to add information after the whole thing has transpired a few days later or whatever, please say that this is added information and put as addendum into it, all right? And again, enter the time and date of your entry so that they know that you have actually put it as a late entry as well. And this is even important as well for your CPR resuscitation, because obviously you can't be recording the care during the CPR itself. You are likely to be recording a few hours later after the whole event, but please record the time. And when the case comes to court, or even at any time you feel that you're not quite right in documenting what has transpired, please do not alter the existing documentation, because it will be obvious to an expert that, you know, the document has been altered. And this is even worse, especially when suddenly you realize the claim has come through and then you decide to alter so that you don't appear to have been in the wrong. In my experience, there are some where I receive documents where the documents, you know, the documents come photostated anyway. So in the most crucial area, they will kind of make sure that the photostating is poor, you know. Well, not that we will just dismiss it. What we would be doing under those kind of circumstances would be we ask for a clearer record of that particular document. And especially if documentation has come through from the nurse's side as well as the doctor's side, we say, okay, the doctor's record has not been very good. Now we look at the nurses to make sure that we can get the supplementary part of the documentation. And it is also important, if you're a consultant, most times when you're a consultant, you fall off the job of documenting to your juniors. It is very important, especially if you have taken part in that care with your junior, especially in a ward round or whatever, and have plans, please make sure you read through what has been recorded. Or even on a better arrangement, make sure you write something that will record what has transpired, what your plans are, if you feel that the quality of what has been documented reflects lesser than what you have got plans for the patient. As I say, do not obliterate errors or remove pages, even if the case is not for court hearing. Make it a habit that if you want to obliterate any errors that you've committed into the documentation, just draw a line across, because just a plain line, no need to go and smudge it, you know, with many lines. Just one line will do, so that anybody else looking at what has been considered an error will know why and what has been written previously as well. And initial it, and also please date it, so that we know that this cancelling was not done many years later when the case comes to court. And it's also important not to question the standard of previous care. You know, when you take over a new patient, you know, who has had an error or damage committed on him, just accurately and objectively document the patient's new condition at the time you assume care. All right, and you combine with a thorough review of prior care treatment records, just to keep the record straight without pointing fingers or blaming others in case the care previously has been in error. I'm going to now share with you how proper documentation of a case can make or break a case. This is not a case that I know of, but it has come from somebody who has authored it into clinical advisor. It was the nurse's documentation that won the case for the hospital. So here, Miss L was an emergency room nurse who saw a 14-month-old child with fever of 2 days and vomiting 5 times the night before. She had actually a bump on her left knee as well, and according to the grandma, has stopped walking. But when Miss L saw, her initial assessment showed the child was awake, alert, a little bit fussy, and she also did a neurological examination, and that was within normal parameters. So she recorded everything faithfully. The doctor saw the patient and recorded that she was dehydrated and fussy, and had a bump on, and the bump was recorded, but and the doctor diagnosed the gastroenteritis, dehydration, and ordered IV hydration and ondansetron, and the child was discharged and told to return if vomiting persisted. Well, the child did come back the next day because she continued to vomit, and Miss L at that time also happened to be in the emergency room and saw the child again, and noted the child was awake, alert, and orientated, and did another neurological examination, which was normal and also recorded as such. This time, another emergency physician saw the child, gave IV hydration and IV ondansetron, and allowed her to stay overnight. And she was admitted into the ward for the dehydration and vomiting the next day, when she also suffered profound neurological deterioration. And the CT scan done showed brain tumor with edema, and a ventriculostomy was performed to release the pressure, but the child suffered residual damage. So of course, the case was brought against the hospital for substandard care. The doctors were told that, if they had done the neurological examination early enough, this particular patient would have not suffered those damage. Well, the doctors testified in that court hearing that they did the neurological examination, although they did not record it down. And another expert says in a neurological case like in this child, they can come with very non-specific symptoms. So the case could not have been picked up earlier. So in the end, the hospital did win the case, and it was all due to Miss L's proper documentation. So you can see that the evidences are all there in our notes. And when the court hears, or when the judge listens to all the evidences, all these are weighed as facts of the case and weighed according to the, in a very unbiased way, according to the probability of it happening as such. So here you can see the relevance of proper documentation that can really make or break your case. Well, it is also very important to understand what the liability and quantum is all about. In every claim for damages, there are always two folds, liability and quantum. And what exactly is liability? Liability, proving liability actually looks at the fault finding process, where I actually help to connect the damage to the care that has been provided by the defendant itself. All right, how they connect, because the care has not been adequate, and because the care has not been adequate, it has brought about the damage, and so the defendant now faces the liability there itself. Now, the second part of the whole thing is actually the quantum, which I don't normally take part in, usually done by a rehabilitation provider, because all these, rehabilitation providers actually look at patients who have been damaged and, try to bring them back to normal state again. And they have a lot of experience in how much the care would cost in doing so, or how much would be involved in sustaining the lives of all these damaged patients. So they would help in this second part, the quantum itself. Now, more important, as I said, in this particular part of the discussion would be how appropriate documentation of your care is important, because sometimes you have caused that damage. Now, if you did not record the state of the patient after the damage has been brought about by you, and this patient moves on to be taken care of by another provider who happens to add more to the injury, that would spell trouble, especially because that part of the injury brought about by the second provider can be heaped on you, all right, at the end, because you have not documented that, after your injury or after your care that has contributed to that injury, you know, the patient went on, the patient no longer wanted you as a provider. So that, you know, remember I said the end of the care, and, you know, how did the patient fare until that period of time should be properly documented, so that, you know, further damage is not attributed to you, but to the second provider. Well, these 5 federal court judges put in a lot of brain work, I'm sure all of you would agree, to bring justice to the nation with regards to the 1MDB SRC case. What I'm actually going to ask of all of you is not to have that amount of brain work put in, but at least put some degree of brain work into your everyday clinical notes documentation, so that when it comes to any case against you, that evidence and that amount of work that you have put in will bring justice either to you or to the patient concerned. So in summary, proper documentation provides evidence of care, which underpins the facts of a case in court. So it's very important to note that everything you record becomes facts of a case in court. And be diligent in all this documentation, as all care can potentially lead to damage. And the justice may be sought many years later, as I told you, if you are involved in the care of minor, it can come very much later. And justice can only be as fair as the work put in to document accurately what transpired in care. I'd like to say thank you for your attention, and I can be reached in the 2 emails that I have actually put in here, just in case you need any assistance, not only for this presentation, but if you're actually by any chance involved in failed medical care. Thank you for the opportunity again to speak to you.
Thank you very much, Prof. YK, and thank you for highlighting the importance of documentation and how it's part of professionalism and standard of care. So I'm going to take a look at the Q&A box. Puisan asks, she says, excellent talk and insight into legal matters, Prof. YK. What happens if documented notes by different caregivers contradict each other?
Mm-hmm. Thank you, Prof. Puisan, for the compliments. Yes, it is not uncommon to have conflicts like this. All right, even the experts, you know, employed by the 2 sides usually have conflicts as well. That means usually the defense lawyer will go all out to support, but that's not the way an expert should be working. An expert, in fact, should be looking at care and how the care has been done well in certain parts and not so well in other parts. So we assess the care from the weight of our experience itself. You know, like for example, if the patient has got sepsis and, you know, you've kind of diagnosed it as something else, like instead of septic arthritis, you've diagnosed it as osteoarthritis and you refuse to take blood cultures for the patient, you are negligent. When somebody else has said, yeah, please take blood cultures, but we don't have the facilities for that in the clinic. So all these will all be looked at in terms of its proportion that has contributed to wrong care. So we all see it all the time. It's because of these conflicts of care that has actually brought about poor care. You know, if only people are more open-minded in terms of how care should be provided. Everybody who suggests ideas about how care should be aligned as well as upgraded in terms of meeting the needs of the patient should be looked at in that sense.
I hope that answers the question, Puisan. Thank you so much, for YK, for answering. Are there any more questions from the floor? So if there are none,
can I
sure,
if
sure,
if at least a parting thought. Now the thing is, it is only when I embarked on this, shall we say, my career or sub-career as a medical expert, did I realize how important documentation is. And I'm very sure this particular presentation probably would be the first, shall we say, eye-opening session for you with regards to the adequacy of our care provision. We tend to leave, as I say, the job to the most junior people and say, okay, let's do a ward round. And here the consultant will be swiftly brushing through the whole place because they're so busy, right? And then at the end, what gets recorded is really poor stuff and nobody looks at it. Consultants don't realize, a lot of us don't, until we are all involved in this kind of care, or rather involved in this kind of experience where we look at care very seriously. I have to comb with a fine tooth comb, you know, to look at where the error is. And our recording sometimes speaks volumes of the kind of care we actually provide for patients. If, you know, it's like they actually have, you know, the judiciary have got a maxim that says, no record means not provided. All right. And you are judged by that as well. So if you have done a lumbar puncture and you didn't record, you will just hope that at least when the lumbar puncture results come back, it reflects that you have done a lumbar puncture. But if the results are also unfortunately missing, but you feel, you know you've done it, but somehow the lab, you know, tragedies have a way of occurring together, right? What you call the cheese hole effect. You didn't record, it was not done, the result didn't come back, missing in action. You are going to be in trouble if the patient had meningitis and dies from it, right? At least if you have done it, you recorded it, but the results didn't come back so that you didn't act early enough, then you can always blame it on the lab. Not that you want to blame, the hospital will still have to bear the responsibility, but then the proportion of damage will then not go onto your insurance or yourself if you didn't get any insurance, but to the hospital insurers for not coming back with the results early enough. So, you know, that's how the proportion part is actually also proportioned. Delay came from the results.
Got it. Thank you, Prof. There's one question in the Q&A. Question from Kamal Kannan. Giving IM injection, do we need to get consent? I think the answer is yes, but Prof, maybe you'd like to answer it.
Actually, the fact that the patient agrees to come into the hospital, you can't be asking for consent for everything. But, you know, those that can suddenly threaten a patient's life, you may have to ask consent, right? This consent idea is actually quite blurred to a certain extent, in the sense that, of course, if you give an intravenous drugs, it can also cost the patient his life, especially if he's allergic to it, right? So do you want to have to take consent for every particular detail? I'm not very sure. Yes, obviously for major surgery, we take consents because the patient has to know. All right. Otherwise, you know, if anything comes through without the consent, is considered a manslaughter kind of arrangement. That means you're taking, or what do you call that? It's not manslaughter, but an intrusion into the patient. All right. So what is important is we have to use our common sense. Now, so if we don't take consents for intravenous, I suppose intramuscular, you just have to tell the patient, I'm going to be putting an injection into your arm or your buttocks or whatever. And the patient has to kind of not or acknowledge consent in that case. But if you actually have a patient who is not, shall we say, conscious or able to acknowledge that, the guardian who is with the patient at that time needs to be told as well.
All right. The same person says sometimes they give injections like diclofenac or methylclopramide. So yeah, I think that was the person's just sharing the context of how it's given. Right. So there's another question from Dr. Lau, I think from HSIJB. Is it necessary to take consent for one procedure more than once? What is the time frame validity for procedural consent?
It's a very interesting question. I don't think there's any time frame in terms of validity that I can actually vouch for. If the patient's condition change, even if you are actually asking the patient for the same procedure that she or he has signed for, it is very important to kind of repeat, even if it's a written consent, or repeat telling the patient and writing into the notes again, yes, patient has previously consented and now agrees again as well to proceed with the procedure. So I think it will be advantageous to write it somewhere into the notes, even if you know that particular consent may be valid, let's say because it was just taken 2 weeks ago. But it is important, even if you don't write it down, take a new consent, I mean, you write it down into the notes that the patient is agreeable to go for the cesarean section. Now that the situation has changed, I will record it down, that the patient has agreed to undergo the surgery.
Thank you, Prof. I hope that answers your question, Dr. Lau. Oh, there's another question. Hang on. All right. So thank you for previous answer. So there is the same person. There is counseling and notes done retrospectively post procedure. Does this make it invalid?
Well, obviously, when you're doing the counseling, you can't be writing the notes. You can obviously, as soon as the counseling is over, write down the notes into the patient's notes. But it's very, very important that you do so. Now, talking about notes that appear after the care, when it's, let's say, if you've done a CPR and you write down the notes after the CPR, obviously, that is still very valid and that is still very, shall we say, acceptable. But let's say you have taken care of the patient and you didn't write very much inside. And then now you hear that the case is coming to court, or the hospital knows that the patient is suing, and then asks you to write a report of what happened. Or, you know, many months later, when the case is kind of reviewed somewhere in the incident or reporting part of care or following M&Ms of the care, you write into the notes or you write somewhere and you file it into the notes, that particular report can be a little bit suspicious and not accepted as being reflective of the truth. In fact, let's say if the doctor claims he has done the neurological examination there, and if the nurses had not recorded properly, like in that particular case that I shared with you, the weight of that particular activity would not have been so much, not so palpable compared to what has been recorded either intra-event or immediate post-event. So be mindful of that, you know, that you think that, oh, I did that, but I didn't record. Now I want to record it as my report. We don't put a lot of weight there, because all this, you know, we have a way of looking at how to align what and build the picture of the care and how adequate it has been. We know where to look. You know, it is actually many boxes of evidences, but there is nothing to hide. There's nowhere to hide, because they go under a huge scrutiny. Not only do we scrutinize as a medical expert, the lawyer seems to know where to look as well. In fact, if you look at some of the requests that comes from the lawyers, because they deal with medical care as well, they know where to look. Of course, the judges would be the ultimate arbiter of what has, what the evidences should be accepted or not accepted, and then how to come to a decision on damage and everything. But, the lawyer's job is to convince the judge. And for me, it is not really to convince anybody, because as an expert, we are supposed to be neutral, but to look at care and, we do praise the care if the care has been good. And our stand would be, we don't support care that has not been quite right, because we have to also look at putting, shall we say, references to support our stand or opinion of why we say that care has been less than adequate as well. Like, for example, if a patient has come with a thyroid nodule, like our previous presenter, Dr. Prashant, has said, if the patient comes with a thyroid nodule and, is like grade 5 and, very malignant, and the report didn't go out that the patient has received, or the care provider who was directly managing didn't receive all this, whatever information, somehow we can get other information that, will come through as well if we scrutinize the notes properly, and then we will know where the care has actually gone wrong.
Thank you very, very much for the lively Q&A, and thank you, Prof. YK, again for sharing your insights. And this is actually a new angle. See why it's important to document things in such a way. And I hope this is something we will address in the professionalism module in the new postgraduate curriculum, if it's not already done yet. And thank you very much, participants, for joining us this morning. So I think that's all. So there are no other questions. Thank you, Prof. YK. Thank you, Dr. Prasad, and participants, and thank you, organizers. Bye-bye.
Thank you. Bye-bye.
Thank you, everybody. Thank you, Prof. Jahan, for being the chair here.